Dear students, this video will be helpful for you to understand about urinary tract infections during pregnancy. Myself, Ruth Kezia, working as assistant professor in Tribhulam College of Nursing. Objectives. In this video, we are going to learn about definition, risk factors, incidence, classification of urinary tract infection, asymptomatic bacteriuria, cystitis, acute pyelonephritis, etiology, pathophysiology, prenatal care and screening, clinical presentation, history and physical examination, treatment for asymptomatic bacteriuria and pyelonephritis, and obstetrical management. Definition. So there are two criteria for definition for UTI. First will be for asymptomatic patient. The next is for the symptomatic patient. In asymptomatic patient, there should be at least 100,000 organisms per milliliter of the urine to say the person has UTI. In a symptomatic patient, especially with the pyuria, there should be at least 100 organisms per milliliter of the urine along with more than 7 WBCs per milliliter of the urine. So this is in case of symptomatic patients. So these are two definitions, and the diagnosis of UTI should be supported by a positive culture for uropathogen, particularly in patients with vague symptoms. So if the patient doesn't have any clear symptoms, the diagnosis should be supported by a positive urine culture for the uropathogen. Okay. Risk factors. What are the risk factors that increases the risk of UTI, and how does pregnancy further increases these risks in women? Okay, so mainly if you see the anatomical placement of the urethra in women, it is placed along with the vagina and the anal orifice. So also the urethral diameter. Okay, the the urethral pathway. Okay, the length of the urethra in a woman is very small when you compare it with a male, so that also causes increased risk of UTI. And as second point is increased blood glucose levels. So the progesterone, okay, is a main hormone that plays a major role in pregnancy, that causes increased blood glucose level. And third is the condition increasing urinary stasis. Again, the progesterone causes relaxation of the smooth muscles on the entire abdomen. Okay, so that causes relaxation of the ureter, that causing the conditions supports this third point, that is condition increasing urinary stasis. And the fourth is the changes in the urine pH, bladder compression, and urethral dilatation. So all these risk factors causes increased risk of UTI during pregnancy for a woman. Incidence: higher prevalence of bacteriuria in Caucasian women during pregnancy, and that is constitute about 6.3%. Prevalence of UTI in pregnancy is 28.7% in whites and Asians, and 30.1 in blacks, 41.1 in Hispanics. Prevalence increases with age, low socioeconomic status, sexual activity, multiparity, untreated pathologies. Next, we'll move on to the classification of UTI. There are two main classifications, that is clinical and anatomical. Under clinical, we have asymptomatic and symptomatic. And asymptomatic constitute about 8%, and asymptomatic constitute about 1 to 2% of the UTI. In anatomical classification, we have lower urinary tract infection and upper urinary tract infection. In lower tract, we have asymptomatic bacteriuria and acute cystitis. In upper tract, it is called as acute pyelonephritis. So this is about the classification of the UTI. Next, we'll move on to the topic, that is one by one. All the classifications we'll study one by one. That is, first is asymptomatic bacteriuria, which comes under the lower urinary tract infection. And asymptomatic bacteriuria is commonly defined as presence of more than 100,000 organisms per milliliter in two consecutive urine samples in the absence of declared symptom. Untreated asymptomatic bacteria is a risk factor for acute cystitis 40% and pyelonephritis in 25 to 30% in pregnancy. So asymptomatic bacteriuria should be treated then and there, even if the patient doesn't have any symptoms like fever, vomiting, dysuria, okay, pyuria or hematuria, but the urine sample shows more than 100,000 organisms per milliliter, that should be treated. Okay, otherwise it's going to cause ascending infection, causes pyelonephritis. Okay, and this usually occurs in early pregnancy. Risk factors include prior UTIs, pre-existing diabetes, increased parity, and low socioeconomic status. Acute cystitis develops in approximately 1 to 2% of pregnant patients, of whom 60% have a negative result on initial screening. Signs and symptoms include hematuria, dysuria, suprapubic discomfort, frequency, urgency, and nocturia. These symptoms are often difficult to distinguish from those due to pregnancy itself. Acute cystitis is complicated by upper urinary tract disease, that is pyelonephritis, in 15 to 50% of the cases. So basically, cystitis is the inflammation of the bladder as a result of bacterial or non-bacterial causes, and if it is not treated, it can lead to upper urinary tract disease, that is pyelonephritis. Next is acute pyelonephritis. Pyelonephritis is the most common urinary tract complication in pregnant women, occurring in approximately 0.5 to 2% of all pregnancies. Acute pyelonephritis is characterized by fever, flank pain, tenderness, in addition to significant bacteriuria. And other symptoms may include nausea, vomiting, frequency, urgency, dysuria. Most cases of pyelonephritis occur in second and third trimester. Okay, so the main difference here is the acute pyelonephritis is characterized by fever. Okay, fever and flank pain, the upper back. Okay, flank pain, tenderness, in addition to significant bacteriuria. Etiology: E. coli, that is Escherichia coli, is the most common cause of UTI, accounting for approximately 70 to 80% of the cases in pregnancy. It originates from fecal flora, colonizing the periurethral area, causing an ascending infection. Other pathogens include the following, that is Klebsiella pneumoniae, Enterobacter species, Staphylococcus saprophyticus, Group B, hemolytic streptococcus, and proteus species. These are some of the uh, organisms that causes UTI. Pathophysiology. Okay, so we have hormonal, mechanical, and that is pathophysiology. How the hormonal pathophysiology is caused. So as I told already, progesterone causes relaxation of the smooth muscles of the whole urinary tract. Okay, so progesterone basically relaxes all the smooth muscles of the abdomen during pregnancy. Okay, so it causes relaxation of the smooth muscles of the whole urinary tract, which causes dilatation of the pelvis and ureter, and vesicoureteral reflex, that is from the vesico means bladder, ureteral means that is the ureter. Okay, from the bladder the urine goes back to the ureter and goes back to the pelvis of the kidney. So that is the that causes the dilatation of the pelvis because of this reflex. What reflex? Vesico-ureteral reflex. Okay, and stasis of the urine, that causes, so if there is reflex, if the urine comes backwards towards the pelvis, that causes stasis of the urine, and that predisposes to infection. Stasis of the urine in the pelvis or stasis of the urine in the kidney. Okay, so all because of the progesterone. That is one reason, that is hormonal. The next we see about the pathophysiology in mechanical. By gravid uterus on bladder, okay, because of the gravity, the weight, the uterus gains about 1500 grams, which is 90 in non-pregnant state, but in during pregnant state it gains weight. Okay, so that gravid uterus along with the baby's weight pushes on to the bladder. Okay, it presses onto the bladder. If you see the position of the uterus, it is anteversion and anteflexion. Basically it sits, the normal position of the uterus is it sits on the bladder. Okay, that is a normal position of the uterus. So if the uterus is gaining weight, so imagine the push on the bladder because of the gravid uterus. The bladder wall, because of that, the bladder wall get pushed up into the abdomen. That causes increased intravesical pressure, and that causes urinary stasis. And also because of the gravid uterus pressure, there will be increased frequency of urination and stress incontinence. In 50% of this causes in 50% in primigravida and less in multigravida. Okay, ureter at pelvic brim. Obstruction of the ureter causes hydronephrosis. So pelvic brim, as you all know, it is the bony, structure. Okay, it is a bony inlet of the pelvis. Okay, true pelvis. So if the kidney is above the true pelvis, the pelvic brim, it's a round shaped bony structure. Okay, pelvic bridge. So above the thing is the kidney, and from that the ureter will be coming out from the kidney, and it goes into the true pelvis, into the bladder. Okay, it connects to the bladder. So when this ureter on the comes on the pelvic brim, that is the bony prominence, if the gravid uterus is going to press on to this ureter, that causes obstruction of the ureters, and that causes hydronephrosis, that is backflow of the urine into the pelvis of the kidney. Okay, this hydronephrosis and hydroureter is more in the right side, and because of the dextrorotation of the uterus to the right side. Okay, so when the uterus, as I told you already, the normal position of the uterus is anteversion and anteflexion onto the bladder. But if the uterus is growing, the uterus will grow straight up. Okay, it will become upright from the position, from leaning onto the bladder, it will become upright, it will be straight. So along with the straight, the uterus will be slightly rotated to the right side. That will be the normal position in the during the pregnancy. Because of this, right, it is rotated to the right side. Okay, that causes pressing, the gravid uterus pressing onto this ureter in the pelvic brim, that causes hydronephrosis. Okay, that is about the mechanical pathophysiology. So we'll see about the pathophysiology, that is hypertrophy of the kidney. Okay, till now we saw the pathophysiology of due to structural, that is mechanical, and we saw about the hormonal. Okay, next we'll see what happens because of the hypertrophy of the kidney. Okay, so basically there is hypertrophy of all the organs during pregnancy. Okay, hypertrophy of the uterus, hypertrophy of the cervix, the vagina. Okay, the ovaries, the fallopian tubes, and all the pelvic organs. Okay, it gets hypertrophied, increased in the number as well as cell, increase in the size of the cell. Okay, the number is increased, also the size of the cells is also increased. That is called the hypertrophy. So when this hypertrophy happens in the kidney during pregnancy, that causes structural hypertrophy as well as functional hypertrophy. What happens in functional hypertrophy? There will be, basically you should know, that is, okay, the glomerular filtration rate is increased. Okay, plasma volume is increased. Okay, if you take the blood volume in a non-pregnant woman, the blood volume is increased by 40% during pregnancy. Okay, the amount of blood, circulating blood, okay, that is increased by 40%, not the RBC. Okay, but I'm saying about the plasma. Okay, the blood constitute corpuscles. Okay, it has RBCs, WBCs, platelets, and plasma, right? So that is the constituents of the blood. But if the only the plasma get increases in during the pregnancy. Okay, the volume of the plasma isn't. Because of that, okay, all changes happens in kidney also. Okay, so because of that, there will be more amount of urine lost. Okay, more amount of urine excretion. Because of more urine is excreted, there will be more loss of urea, creatinine, glucose, amino acids. So all essential nutrients are got lost because the more urinary excretion. Why there is more urinary excretion? Because of the increased plasma volume. Why there is increased plasma volume? Because the hormonal changes during the pregnancy. Okay, so we'll see here increased renal blood flow. Okay, that causes increased glomerular filtration rate by 40%, and increased plasma volume by 60%. All these are the normal changes during pregnancy because of the hormones. Okay, and decreased blood urea, nitrogen, and serum creatinine. All these hormonal changes, four hormonal changes which are normal, causes glucosuria. That is, glycosuria means increased amount of glucose in the urine. Okay, so this glycosuria is sometimes caused because of the filtration by the kidney. It means the the baby also passes urine, right? So that also causes glucosuria, and that causes increased renal blood flow and increased glomerular filtration rate. That leads to decreased tubular reabsorption and increased loss of glucose, amino acids, etc., and sodium and fluid retention. So all these changes will return back to normal within 4 months after delivery. Okay, so all these changes are normal, but once after delivery the mother will be fine. Okay, for so if we take this HbAs, okay, what is HbAs? It is a hemoglobin A which carries responsible for carrying oxygen. Okay, it is found in all adult hemoglobin. Okay, it carries oxygen to the entire body. So if the patient has something abnormal with this HbA hemoglobin profile, then we have to do screening for urine culture for each trimester. Same way, this urinary tract infection, that is asymptomatic bacteriuria, percentage is doubled for women with sickle cell trait. Clinical presentation. History. The presentation varies according to whether the patient has asymptomatic bacteriuria, low urinary tract infection, or upper urinary tract infection, that is pyelonephritis. Burning with urination, that is dysuria, is most significant symptom in pregnant women with asymptomatic cystitis. Other symptoms include frequency, urgency, suprapubic pain, hematuria, and pyuria in the absence of systemic symptoms. Okay, so the main symptom will be burning with urination, that is dysuria. The usual history, what will be the history the mother gives? The usual complaints of increased frequency, nocturia, suprapubic pressure are not particularly helpful because most pregnant women experience these as a result of increased pressure from the growing uterus, expanding blood volume, increased glomerular filtration rate, and increased renal blood flow. Pyelonephritis signs and symptoms often include fever, more than 38 degrees Celsius, shaking, chills, anorexia, nausea, vomiting, costovertebral angle tenderness. Okay, so previously we saw the main symptom for asymptomatic bacteriuria is burning maturation. But if it is pyelonephritis, it means if the UTI is advanced and has reached the kidney, it means the patient will have fever more than 38 degrees Celsius with the chills, anorexia, nausea, vomiting, and flank pain. In physical examination, you should be considered in relation to the duration of pregnancy. A thorough physical examination is recommended with particular attention to the abdomen. Suprapubic or costovertebral tenderness may be present. In asymptomatic bacteriuria, no physical findings are typically present. Symptoms may arise intermittently only to be overlooked because of lack of persistence or severity. Pelvic examination is recommended in all symptomatic patients with the exception of third trimester patient with bleeding to rule out vaginitis and cervicitis. In patients with cystitis, tenderness can be often elicited with isolation of the bladder on pelvic examination. Okay, so if it is cystitis, there will be tenderness on the bladder. Okay, if it is pyelonephritis, there will be suprapubic or costovertebral tenderness. Okay, the thorough physical examination is recommended with particular attention to the abdomen in case of UTI in pregnant women, except in case of women with who are in third trimester with the bleeding. There we should consider, okay, we should suspect for vaginitis and cervicitis. In other cases where the mother gives a history of flank pain or suprapubic tenderness or costovertebral tenderness, you should consider thorough physical examination. Patients with pyelonephritis have usually greater than 38 degrees Celsius flank tenderness upon palpation and an ill appearance. Pain may also be found suprapubically with palpation. Assessment of fetal heart rate on the basis of gestational age should be included as a part of evaluation. Often owing to maternal fever, fetal heart rate is elevated more than 160 beats per minute. So because of fever, there will be increased pulse rate, right? So because of that, if the mother is having pyelonephritis, there will be fever for the mother. Because of this fever, the fetal heart rate is also increased more than 160 beats per minute. Treatment. Okay, this is about the diagnosis and screening, history and physical examination. Then we'll come to the treatment. Treatment regimen for pregnant women with asymptomatic bacteriuria or UTI. Okay, there is a different treatment regimen for asymptomatic bacteriuria. Okay, different for pyelonephritis. Okay, for first is for the asymptomatic bacteriuria. We can give nitrofurantoin monohydrate macrocrystals 100 milligrams orally twice daily for 5 to 7 days, or amoxicillin 875 milligrams orally twice daily for 5 to 7 days, or amoxicillin clavutate 500 by 125 milligrams orally thrice daily for 5 to 7 days, or cephalexin 500 milligrams orally 4 times daily for 5 to 7 days, or fosfomycin 3 grams orally as a single dose with 3 to 4 ounces of water. Treatment success depends on the eradication of the bacteria rather than the duration of the therapy. So as long as the urine culture or the urine routine comes negative for the uropathogens, the treatments should be continued. The pregnant women who have 3 or more episodes of cystitis or bacteriuria should be started on daily antibiotic prophylaxis for the remainder of the pregnancy. Regimens for daily prophylaxis include nitrofurantoin 100 milligrams at night or cephalexin 200 to 500 milligrams at night. Treatment for pyelonephritis. The standard course of treatment for pyelonephritis include hospital admission, IV administration of antibiotics until the patient is afebrile. So we see that the main criteria for pyelonephritis is the patient complaining of fever more than 38 degree Celsius. Okay, so in that case you have to admit and provide IV antibiotics until the fever subsides. Surgical care is rarely indicated. A retrograde stent or a percutaneous nephrostomy should be placed to remove the ureteric colic or decompress an obstructed infected collecting system, and ESWL is contraindicated. Extracorporeal shockwave lithotripsy is contraindicated in pregnancy, and in rare case where invasive surgical treatment is indicated, the operation is planned for the second trimester. Okay, in first trimester, if you do, you will injure the um, fetus, okay, because of the central nervous system is developed in that time. During the second trimester, central nervous system is somewhat developed fully and will have some space, and be a third trimester the baby is fully grown, there will be no space to do surgery. So ideal time for doing surgery will be in the second trimester. Okay, the baby will be grown to some extent. Okay, and the baby can withstand the surgery, withstand the medications and everything, and you will have some space to do the procedure. Then we'll go to the obstetrical management. Pyelonephritis itself is not an indicator for induction. If the patient has pyelonephritis, he should not consider induction, okay, but he should consider only treatment of this infection. But if the induction is done in women with pyelonephritis because of the gestation age is reached, okay, and the mother is term, okay, if you want to do induction, you have to make sure the patient is not having fever. Wait until the patient is afebrile for the safety of the mother and the fetus. Prevention of recurrence. If the preventive therapy is utilized, reasonable options include nitrofurantoin during postnatal period. Okay, this is during postnatal period. If you want to prevent UTI or pyelonephritis, you can consider nitrofurantoin 50 to 100 milligrams orally at bedtime, or cephalexin 250 to 500 milligrams orally at bedtime. And complications, hypoxic fetal events because of placental hypoperfusion due to mother's infection can occur, and preterm labor delivery leading to increased mortality and morbidity. Okay, so complications are hypoxic fetal events that can cause okay, whatever complications because of the hypoperfusion of the placenta, as well as preterm labor because of the pain. Okay, we see the mother has suprapubic pain, okay, flank tenderness, okay, costovertebral angle tenderness. All this pain uh, can be a precursor for a true labor pain that can lead to labor also. In that case, the mother may have a preterm labor, and that it can lead to mortality and morbidity. Okay. So I hope you gain some knowledge about the urinary tract infections during pregnancy, what happens there, what is the definition, incidence, the etiology, and we saw the various pathophysiological conditions due to hormones, okay, due to mechanical pressure, and due to structural and functional hypertrophy of the kidney, and that how all this causes UTI in pregnant women, what are the diagnosis and what are the treatment regimen for different kind of UTI. Okay, thank you all.